Hi, in this video we will be studying cementation of fixed partial dentures. Cementation, also known as luting, is very important in determining the success of fixed partial denture because it is also going to aid in retention. So cementation is defined as the process by which a restoration is cemented on tooth using a luting agent. Luting agent meaning cement in layman words. So there is provisional luting and definitive luting. Provisional is for interim restorations or temporary restorations, and definitive cementation is for permanent cementations. Now we will not be discussing provisional restorations in detail. That will be covered under interim restorations video. For definitive cementations, we will be discussing all the necessary cements and the procedure for luting them. So let's have a look first at the ideal requirements of a luting agent. The luting agent should be something that has a long working time so that you have enough time to load, mix and place it in the mouth. It should adhere well both to the tooth structure as well as the alloy. It should not only just bond to the tooth or the restoration. It has to be a bridge between the restoration as well as the tooth. Should provide a good seal. There should be no micro leakage of that cement. It should be not toxic to the pulp. It should have pulp protection phenomenon to it. Then it should have adequate strength related properties because mechanically there will be a lot of load coming on that restoration. So the cement should also be able to function well under the stress environment. Should be compressible in thin layers. We do not want very thick cement because we want to have our preparations very conservative. And thicker the cement, the chances of discrepancies are more. It should have low viscosity and solubility. It should not just freely flow out and it should not dissolve in the oral fluids. So these are the requirements of a luting agent. We have amongst us a few commonly used luting agents in FPD. So zinc phosphate cement, zinc oxide eugenol cement, zinc silicophosphate cement, zinc polycarboxylate cement, glass ionomer cement and resin cement. So these are a few commonly used cements in dentistry for restoration of fixed partial dentures. This is a small summary of the properties of the resin cement, glass ionomer cement, composite cement, adhesive cement, zinc phosphate cement. So all the routinely used cements are concised in this table. So let's have a quick look at what these properties are. The first one is film thickness. Film thickness meaning the thickness of the cement, the minimum thickness of the cement that can provide luting agent property. So ideally it should be low. We do not want very thick cements. So cements like zinc phosphate, polycarboxylate, glass ionomer have less than 25 microns luting thickness, whereas resin ionomer, that is resin modified glass ionomer cement, composite resin and adhesive resin have greater film thicknesses. So you will need a thicker die spacer for these three cements, that is resin modified GIC, composite and adhesive resin. Now coming to working time. Working time is the amount of time that the operator gets from the time he starts mixing to the initial set. So working time should be a little considerably long because we want enough time to mix and the cement should not just set while the operator is trying to handle it. So zinc phosphate has a good working time. Zinc polycarboxylate has a very low working time. That is the disadvantage of polycarboxylate cement. Glass ionomer and the other resin cements have relatively good working time. Especially with composite and adhesive resin, most of these cements can be dual cure. So you can control the working time in a better way. Setting time. Now setting time is the amount of time required for the cement to set. It should ideally be short because if it is long then the cement will be subjected to oral fluids and there will be a lot of micro leakage along the margins. So all of the cements have adequate setting time except for resin cement, which is shorter and which is most desirable because it bonds chemically to the tooth and it cures. It has a resin component and a glass ionomer component. So it is a very desirable property of the resin ionomer cement and relatively the other cements have similar window of setting time. Now coming to compressive strength, that is how much load can it take along the long axis, compressive forces. So definitive luting agent should have high compressive strength. All these cements have good compressive strength except resin modified GIC and polycarboxylate. These have relatively lower. Even zinc phosphate has lower compressive strength compared to glass ionomer and resin cements. So these cements are weaker as compared to the other three. Then elastic modulus. Elastic modulus is the property of a material to withstand the bending kind of forces. How much elasticity does it produce? So it should be similar to that of dentine and enamel. If it is closer to enamel and dentine, it will sustain the forces easily. If there is a lot of variation in the modulus of elasticity in comparison to the natural tooth, then the cement will distort. So all these cements which are tested have more or less similar properties compared to enamel and dentine. So these are accepted as definitive luting agents. Then coming to pulp irritation, which should definitely be low. We do not want the material to cause any irritation to the pulp. Polycarboxylate cement has very good properties when it comes to pulp protection. The other cements are relatively not as good as polycarboxylate. Then comes solubility. So it should not be soluble. The cement should not be soluble in the oral fluids or saliva, which should be very low. So glass ionomer is not really soluble, and resin modified glass ionomer is also not very soluble in the oral saliva, but you require a lot of isolation for cementation with glass ionomer, because contamination with glass ionomer of saliva will cause changes in the setting property of glass ionomer cement. Then the property of micro leakage. Micro leakage is along the margins when the cement starts to leach out. So that property should also be very low. It is low to very low and very low in glass ionomer based cements and adhesive resin cement. But it is high in composite resin cement and polycarboxylate and zinc phosphate cement. So all these cements are going to cause more micro leakage. Then comes removal of excess, which should be very easy for the operator. You don't want the cement, excess cement bulk to be in the gingival tissue. So it is easy when it comes to zinc phosphate, and it is difficult when it comes to adhesive resin cement. And the last factor that we are going to see about these cements is the mode of retention. How retentive is the cement? So it should be very high. A definitive luting agent should have high retentive features. So we have these resin based adhesive cements and resin modified glass ionomer cements which have high adhesion property to the tooth, whereas polycarboxylate does not adhere very well to the tooth. So the retentive features of polycarboxylate is comparatively less. So this was the summary of all the luting agents that can be used in fixed partial dentures. So based on the properties that we discussed, we are going to now see the advantages and concerns and precautions of the luting agent that we have already seen earlier. So adhesive resin cement, as the name says, it is going to adhere to the tooth structure. There is an additional adhesive molecule required for bonding of these cements. So examples of this is Multilink, Variolink, which are all manufactured by Ivoclar. So adhesive resin cements have good adhesion property, but again they have higher film thickness and poor moisture control related issues. So the clinician has to be precautious when moisture control is to be established. Composite resin, for example, Panavia. Then you have Relic cement. These two cements are composite resin based. They do not require additional adhesive as such. They can be dual cure or self cure or light cure. So they have low solubility, which is an advantage. But again, they have a high film thickness and bonding requires moisture control. So that is a precaution to be noted in case of composite resin based cements. Then glass ionomer, it bonds chemically to the tooth. It is excellent in bonding. It has good translucency, but solubility can be a problem if moisture control is not established, and you should avoid early moisture exposure. In long term setting, the glass ionomer is not soluble. Micro leakage is relatively lesser. But at the early setting time, because the moisture is going to change the setting reaction of glass ionomer, you have to be cautious. Then reinforced zinc oxide cement, which is biocompatible but has low strength, and it is used only for very retentive restorations. So if your restoration is very retentive, you will not add another retentive cement to it. You can use reinforced zinc oxide eugenol cement. Resin ionomer, that is resin modified glass ionomer. It has low solubility and low micro leakage, which is a chief advantage of this cement. But the concern comes with the water sorption, and it is to be avoided with ceramic restorations. You cannot use resin modified GIC with complete full ceramic restorations like lithium based ceramics especially. So these Emax crowns and very translucent materials, you will not use resin modified GIC. Then comes zinc phosphate, which is the gold standard. It has been historically used for most cast metal restorations, but there is a small problem with that, that is solubility and micro leakage, and used for traditional cast restorations. And lastly, we have the zinc polycarboxylate cement, which has excellent pulp protection activity. It is very biocompatible but has lesser strength and high solubility, and more importantly, it is very difficult to mix at the given proportion. So it has lesser working time, plus the Manufacturers' instructions for mixing are very stringent, so you have to be very careful while mixing polycarboxylate cements. So now we've already seen the required properties of a luting agent and how are they going to affect your restoration. So let's have a look at the summary of these things. Suppose if you have a cast crown and a cast metal ceramic crown with the FPD or a single crown, a bridge, then which cements would you use? So we have a list of 1 to 7 cements here in the index. First being adhesive cement, second being composite resin, third is glass ionomer. Then you have reinforced zinc oxide, eugenol, resin ionomer, zinc phosphate and zinc polycarboxylate. So all these cements can be successfully employed for cementation of cast crown restorations and bridges. Then coming to crown or partial fixed partial denture with poor retention. So for poor retention, you will definitely need something very adhesive. So that is obtained by adhesive resin cement. And the other cements are relatively contraindicated in such a situation. For a metal ceramic crown with porcelain margin, you can use any of these cements again. Then casting on patient with history of post-treatment sensitivity. In sensitivity cases, you will use zinc-based cements. So number 4 is reinforced zinc oxide and number 7 is zinc polycarboxylate cement. So you will consider zinc based cements here. Then pressed high lucite ceramic crown. If there is high lucite, you will not use resin modified glass ionomer cement. You will definitely go for a resin cement. So you will go for adhesive and composite resin but not resin modified glass ionomer cement. Then last is slip cast alumina crown. You can go for all except resin based glass ionomer cement. So resin based glass ionomer cement is not very preferred for aesthetic restorations, slip cast alumina crowns and ceramic crowns. Then comes ceramic inlay, ceramic veneer, resin retained, that is your Maryland, Rochette. All these have to be resin bonded, adhesive resin or composite resin based. The other cements are not very useful in these kind of restorations. For cast, post and core. So if you have a cast post that is fabricated in the lab, you are not using a prefabricated post here, you are using a cast post with a core. So this could be metal or it could be zirconia. You ideally use resin cements or you can use glass ionomer or resin based glass ionomer cement or you can use zinc phosphate cement. You will need a stronger cement. A weaker cement like ZOE, reinforced ZOE or zinc polycarboxylate cement will not suffice for that purpose. So here you need a very strong cement which can be resin based or ionomer based. Now coming to the quick facts that we need to remember for luting agents. First is the cement should fill only half of the inner cavity of the crown. Otherwise, it is going to cause excess cement leakage from the crown and it should be bubble free. You cannot overfill the entire crown. If the entire crown is filled, the risk of bubble entrapment increases. It also increases the time and the pressure required for setting and increased efforts will be required to remove the excess cement. So because of these reasons, that is for bubble entrapment, increased time and pressure for setting and the increased efforts to remove excess cement, you will fill only half the crown with the luting agent and against pressure any which ways it is going to flow because these cements have a very good flow property and it will be covering the entire surface of the tooth. The reported ideal thickness of luting agent is around 25 to 40 microns. So this is the reported luting agent thickness, 25 microns to 40 microns. So subsequently you will provide a dye spacer equal to that amount. What is a dye spacer? A dye spacer is an application of nail polish like material that is applied on the dye. It is going to provide space for your final cement. If you do not give dye spacer, then the crown will be in direct intimate contact with the tooth and there will be no space for the luting agent. So this is a dye spacer which is given for luting agent. It has to be of the same thickness. So 20 to 40 microns of dye spacer is provided as a space for luting agent and it functions as a spacer. It provides room for luting agents. So earlier we have discussed the different types of prosthetic designs and the options of luting agents. Here we are going to see a few clinical considerations and which kind of luting agent is best suited for that. So the first one is hypersensitive vital teeth. You are going to use zinc polycarboxylate or reinforced ZOE which is biocompatible with the pulp and you are going to avoid zinc phosphate and GIC or chemically activating cements. Then hypersensitive teeth with average retention form. So here the retention form is average. You are going to use zinc polycarboxylate and avoid the same cements. Then hypersensitive teeth with more than average excellent retention. Here the retention is excellent. You will use reinforced zinc oxide eugenol cement. So basically in hypersensitive teeth you are going to use only polycarboxylate or ZOE, reinforced ZOE. If the retention is average, then polycarboxylate. If the retention is excellent, then reinforced ZOE. So these are the hypersensitive areas, and these are the cements which are used. The cements to be avoided are zinc phosphate, chemically acting cements like glass ionomer cements or composite resin cements. Then in long span bridges, so if you have a long span FPD with high masticatory stresses and the abutment teeth are not sensitive, you will use a stronger cement because you are wanting to take support from a lot of teeth. So you will not use something which is weak. So zinc polycarboxylate is not preferred. Zinc phosphate is really preferred because of favorable modulus of elasticity. Around 12 to 13 is the modulus of elasticity, and in a longer bridge you will want the stresses to be nullified. So you don't want something very away from enamel and dentine. The modulus of elasticity has to be closer to that. So zinc phosphate provides excellent features for that. Then you have glass ionomer and resin modified glass ionomer cement which chemically bond and which can also serve the purpose. Then coming to non-vital teeth with average excellent retention form. In that case you will use zinc phosphate. If the retention form is excellent to average, you will use zinc phosphate cement. And if non-vital teeth having poor or lower retention form, you want chemical bonding, so you can use glass ionomer cement or resin modified glass ionomer cement, or definitely you can use adhesive cement because they adhere very well to the crown and the tooth both. So here you will need more adhesive kind of a cement, and here you will need more mechanically supporting kind of a cement. So in excellent retention form you will use zinc phosphate, and in average or lesser retention form you will use glass ionomer and resin based cements. Then like we discussed earlier, for mutilated teeth which require a post and core restoration, it could be a cast for or a prefabricated post, you will use adhesive resin. You can also use glass ionomer cements. Patients in whom complete isolation is difficult. So if isolation is difficult, like in posterior mandibular region, you will go for zinc polycarboxylate or RMGIC cement, and you will avoid zinc phosphate and glass ionomer cement. Patients with xerostomia, that is reduced salivation, you can use the ones which are contraindicated here. So you can use glass ionomer and resin modified glass ionomer because they have a fluoride releasing action. So that is going to help you in the tooth mineralization. In patients with high caries index, you will use glass ionomer and resin modified glass ionomer cements. Then coming to the last two clinical conditions under this heading, we have children with large pulp chambers. So here you will use zinc polycarboxylate because it is very safe to the pulp. So even if the pulp chamber is close to the restoration, zinc polycarboxylate is relatively safer as compared to zinc phosphate or glass ionomer. So these should be avoided. And teeth prepared to receive partial veneer crown or retainer. So in a partial veneer crown, already the retention form is compromised. In that case, you will want to go for a more adhesive option. So you have adhesive resin, RMGIC, because it has less solubility and micro leakage. And you will avoid glass ionomer because it is translucent, which makes enamel adjacent to the metal casting appear slightly grey. So it will have changes on the shade. And zinc phosphate also you will avoid. So which are the cements that you will use for partial coverage crowns? That is adhesive and RMGIC. These are very important clinical considerations that you have to remember, because you can have questions not only based on the clinical considerations but based on the property, based on a combination and permutation of these. You can have cases which could be children with large pulp chambers with a not very retentive crown. So again you have to analyze the situation and come to a conclusive answer. You can have 2-3 answers which are similar and applicable to that clinical scenario, but you have to rule out based on the property that we have discussed as to which cement is best suited for what scenario. So coming to the frequently asked questions from this topic, like I told you, the properties of each cement are very important. Modulus of elasticity is important. Then solubility properties are important. Strength related properties are important. Bonding properties are important. So these properties, which is the better one of the rest, is important. Then zinc polycarboxylate has good pulp protection activity. So that is again very important. Choice of luting agent based on the type of restoration and based on the clinical situation as we discussed. So for metal crowns and metal ceramic crowns, you can go for all the luting agents that we have discussed. And for ceramic based crowns, you will usually avoid resin modified glass ionomer cement and glass ionomer cements. Based on clinical situations, we saw hypersensitivity based on the amount of retention, based on the kind of preparation, based on the age groups. So all these criteria are very important, and you have to understand why each cement is specifically employed for that case of for the cementation of FPD. Then thickness of die spacer has to be in the range of 20 to 40 microns, and cement must be filled only half the intaglio surface of the ground. These questions have already come in exams before, so that is why I have purposely included in the frequently asked questions. So please remember that 20 to 40 microns is the amount of preferred die spacer for any cement, because the film thickness is going to be in that range. So this is all about the cementation procedure, about the cements, about their properties, and I hope this video will help you understand this better. Thank you for watching this video.